It's a pleasure to be here. I'm going to today cover thyroid nodules, suspending thyroid nodules, possessing indeterminate cytology, 10 and 15 millimeters in size. Let me talk about some introduction, some words about introduction. Thyroid nodules are very common. It's about 5% in adults, and it's a common entity. But when we look carefully into the thyroid gland by ultrasound, we can see easily it consists more than 50% in an adult. Surgery is not, it's the fact that surgery is not practical for all thyroid nodules. So we would like to take a triage, what we say about that, how can we detect thyroid nodules requiring surgery. For this purpose, we need a screening test. American Thyroid Association has guidelines for selecting thyroid nodules requiring fine needle aspiration biopsy or not. One little question rising about that is a FNA application a diagnostic or screening test. When we think about its constituting, we can say that its condition in thyroid gland such as differentiated thyroid carcinoma, medullary carcinoma, anaplastic carcinoma, and non-Hodgkin lymphoma, yes, you can make a diagnosis. You can use it as a diagnostic test. But if we think about a large family like follicular and Hürthle cell lesions, you cannot, it's not useful as a diagnostic test, but the screening test. Management of thyroid nodules with indeterminate cytology has still been one of the most challenging issues in thyroidology to date. So, different management guidelines for thyroid nodules have been striving to enhance diagnostic accuracy and avoiding unnecessary biopsy rates beyond the surgery by describing the different thyroid size thresholds. So we can describe it as size cutoff points of thyroid nodules. So these cutoff values have been assigned in order of scheduling a thyroid nodule to undergo an interventional procedure FNA prior to decision on evaluating this challenging entity with surgical modalities. Size cutoff of 10, 15 and 20 millimeters has still been arising as one of the most challenging issues. Of note, the size cutoff of 10 millimeter particularly remains crucial in the management of thyroid nodules with worrisome clinical findings, sonographic features, and/or cytology. The last 8A management guidelines recommended US FNA for the nodules over 10 millimeters for high to intermediate suspicion sonographic pattern. Nevertheless, the cutoff size of 10 mm has still could not have been underestimating issue for the management of thyroid nodules so far. Therefore, some recommendations on the size selection criteria for US FNA have been set at that cutoff value. For this purpose, AAC AME recommended FNA for the ones thyroid nodules over 10 mm for solid and hyperechoic features on sonographic appearance. Furthermore, the novel euthyroids, based on a review on the literature comprising a thyroid, we can say US lexicon. It's a kind of US lexicon for thyroid nodules. They proposed FNA for the nodules, thyroid nodules over 10 mm of a high risk category. Some authors reported high specificity with and low rate of unnecessary biopsies in the 2017 ACR guidelines proceeding from the larger size cutoff. What does it mean? 25 mm for mildly suspicious nodules and 15 mm for moderately suspicious nodules. In addition, it was denoted the ATA and Korean guidelines were being exhibited the high sensitivity, whereas ACR, American College of Radiology guideline was lesser significant in terms of diagnostic performance of US FNA for the indicated nodules. Therefore, it was stated that the thyroid nodules with low or intermediate suspicion for the last ATA, American Thyroid Association, and the Korean guidelines were undergone FNA at a size cutoff of, we see here again, 25 and 15 mm respectively, that could produce significant change in the percentage of thyroid nodules requiring FNA application. To this end, we recently investigated, we published a paper before 2 years, whether the cutoff points of 10 and 15 mm have the efficacy on 3 diagnostic tools. We investigated for this purpose strain elastography, US FNA cytology, and histopathology. And the mentioned current outcomes on the basis of the size both over 10 and 15 mm reveals no significance. Therefore, it may be alleged that the possible correlation between the size and Tsukuba elasticity score 4 and 5, which is most, which with that you can think about that you much more possibility to be a malignity, malign nodule, malignancy. 4 and 5 of Tsukuba elasticity score of strain elastography. 4 and 5 get stronger as the cutoff value was designated assigned as 15 mm. In the same way, McNamara test was used to compare in our study the nodules over 10 and 15 mm, and no significance was revealed with an additional calculation of the area under the curve. Hence, it may be concluded that the association between the nodule size, thyroid nodule size, and the precise histopathology gained strength as the cutoff point was raised, increased, which is 15 millimeter, compared with the lower one, 10 millimeter. However, the real challenging point is to be able to, that's why I would like to say about cutoff size points, and we can turn on the talk about indeterminate cytology, which is also a very important and controversial issue in thyroidology to date. Indeterminate cytology actually includes 3, 4, and 5 categories, 3, 4, and 5 of the Bethesda system. The Bethesda system for reporting thyroid cytopathology. Yes, I've just said before that. However, the real challenging point is to be able to decide as far as irreproachable management of the ones with controversial conditions, such as AUS FLUS, means atypia of undetermined significance, and follicular lesions of undetermined significance, which constitutes third category of Bethesda system. Well, why do we have the Bethesda system? Before the Bethesda system, we really didn't have a uniform terminology. So it's important for us to speak same language to provide clarity of communication. And also it's important to exchange of information across institutions. Bethesda system, the Bethesda system for reporting thyroid cytopathology, first gathered and published in NCI conference in Bethesda, Maryland, 27. And then second second edition of Bethesda system was published also as an atlas book in 2017. Today it's widespread acceptance. It has Bethesda system TBSTRC has a widespread acceptance in the US, in the States, and elsewhere. It's also endorsed by ATA, American Thyroid Association Management Guidelines. Here you see an important table. You see here actually 3 columns in the table, 3 columns, because of first column is first edition of TBSTRC, the second one, second edition without NIFT-P, and the third column is second edition with NIFT-P. NIFT-P is an so current terminology for the thyroid nodules, and it's generally usually accepted as an indolent tumor. So you can see easily here when you include into when you introduce as its introduction to the procedure what is NIFT-P, their risk of malignancy attenuates comparing the one at the middle column. Here, diagnostic categories, because the test system has 6 base diagnostic categories, but I can say that we can take a line from here. Below this line is important for surgical requirement, surgical necessity. So 1, 2 is a benign, 3, 4, 5, and 6. 6 is malignant. 6 describe malignant thyroid nodules. The controversial issue is indeterminate cytology 3, 4, and 5. You can see also this TBSTRC also gives us their usual management for surgeons, for physicians, providers, pathologists, endocrinologists, etc. Here you can see also usual management for all these conditions. The ATA, American Thyroid Association Management Guidelines for Thyroid Nodules, recommended repeat FNA and molecular testing for a panel of mutations, BRAF, RAS, including HRAS, NRAS, and KRAS, red PTC1, red PCC3, PAX-A, PPR gamma, to supplement malignancy risk assessment in lieu of proceeding directly with a strategy of either surveillance or diagnostic surgery for third category called AUS FLUS. This slide also describes using genetic molecular testing for these conditions, for follicular adenoma, NIF-TB, invasive. In fact, NIF-TB also means non-invasive encapsulated follicular variant of papillary thyroid carcinoma, and one just neighboring this column is invasive encapsulated follicular variant of papillary thyroid carcinoma. Follicular carcinoma classic, or it's also known as conventional papillary thyroid carcinoma. The last ATA management guidelines recommendations for suspending nodules. It also suggests either surveillance or diagnostic surgical excision for an AUS FLUS thyroid nodule, depending on clinical risk factors, sonographic pattern, and patient preference, as in case repeat FNA cytology, molecular testing, or both are not performed or inconclusive without specifying any cutoff size. So you see here, the last ATA guidelines also did not recommend any cutoff size for these kinds of conditions. We also published a paper approximately February 2020. We might suggest surveillance as an outcome of this paper article. We might recommend that surveillance for the thyroid nodules with 10 to 15 millimeter with category 3 of indeterminate cytology, TBSTRC, for both first and second edition, because no any change for its evaluation to date. Harboring high to intermediate suspicion sonographic pattern, low clinical risk factors with repeated FNA cytology, molecular testing, or both are not performed or inconclusive, comparing the ones over 15 millimeters. So, in short, I would like to say that we might suggest surveillance instead of undergoing surgery if your thyroid nodules between 10 to 15 millimeters with indeterminate, with a cytology of indeterminate cytology, and harboring these conditions. You see here these conditions. What I want to say, what I want to cover, that low clinical risk factors is important to reach this decision. And showing you my own case here. This case describes, firstly, I performed ultrasonography, thyroid neck ultrasonography actually for this case, and here you see a solid hyperechoic. Here you see a hyperechoic solid nodules with, you see here, irregular borders with micro and macro calcifications in B mode ultrasound. And then I performed a Doppler sonography for this case, and you see here it has intra and peripheric vascularization in the nodule. After that, I performed ultrasound guided FNA application. Here you see this tract of the needle, fine needle, and I use very fine, I can say maybe so finest needle, 27 gauge I use. Usually I'm used to 27 gauge fine needles for these cases. After that, cytologic evaluation revealed category 3 for this case, and we performed surgery for the reasons I've just expressed you before, just before we perform surgery. And for surgical procedure, we choose left thyroid lobectomy. And here also I used intraoperative nerve monitoring to be able to preserve recurrent laryngeal nerve. And here you see an anatomically left recurrent laryngeal nerve at its entrance to the larynx, at the tip of the probe of INM. So to summarize, management of thyroid nodules with indeterminate cytology has still been one of the most challenging issues in thyroidology, and different management guidelines have been striving to enhance to diagnostic accuracy by describing the different thyroid size thresholds. Size cutoff of 10, 15, and 20 millimeters has still been arising as one of the most challenging issues, and some recommendations on the size selection criteria for US FNA have been set at 10 millimeters. We recently investigated whether the size cutoff of 10 and 15 millimeters have the efficacy on 3 diagnostic tools, which leads to an outcome of an association between nodule size and precise histopathology gains strength as the cutoff point value is was raised, means 15 millimeters. However, the real challenging point is to be able to decide as far as controversial conditions such as AUS FLUS of indeterminate cytology, and current ATA management guidelines recommended repeat FNA and molecular testing for a panel of mutations BRF, HRES, NRES, KRES, red PTC1, red PTC3, PPR 8 and PPR, PAX8 or PAX8 and PPR gamma in order to deciding strategy of either surveillance or diagnostic surgery for AUS FLUS cytology. It also suggests either surveillance or diagnostic surgical excision for AUS FLUS depending on clinical factors, sonographic pattern, and patient preference as repeat FNA, molecular testing, or both are not performed or inconclusive without specifying any cutoff size. It might be suggested, vastly, it might be suggested the surveillance for the thyroid nodules 10 to 15 millimeter with category 3 of indeterminate cytology, TBS or TC for both editions harboring high to intermediate. Why high to intermediate? Because if low suspicion or intermediate, we actually do not decide, do not think about FNA application. High to intermediate suspicion, sonographic pattern, low clinical, important point, low clinical risk factors with repeated FNA cytology. Molecular testing or both are not performed or inconclusive, comparing the ones over 15 millimeters. Well, thank you for your attendance. If you have a question, we can talk about it.
Hocamıza ben teşekkür belgesini taktım.
Hocam, katılımlarınız için çok teşekkür ederiz.